Chronic simple glaucoma or open-angle glaucoma is a condition in which there is a bilateral non-congestive increase in the intraocular pressure in the absence of angle closure, leading to optic nerve damage and visual field defect. From the definition, the glaucoma in this condition not associated with closed angle, but in this condition the angle is opened. This is the first one. The second thing is that the pressure is slowly progressive. It is not congestive like in cases of closed angle glaucoma. The incidence of open-angle glaucoma equally affect both males and females. The age of presentation usually above 50 years old. It is the most common type of glaucoma. 90% of cases of glaucoma are open-angle glaucoma. Glaucoma is the second major cause of blindness worldwide. The first cause is cataract and the second cause is glaucoma. Unfortunately, 6 million persons are bilaterally blind because primary open-angle glaucoma. Etiology. What is the cause of open-angle glaucoma? The aqueous humor in this condition accumulates in the anterior chamber and increases the intraocular pressure, but in slowly progressive manner. If we see here, we will notice that the iris in its normal position in comparison with closed angle glaucoma, in which the iris close the angle. But here the pathogenesis not with the iris but with the trabecular meshwork, which become more sclerosis and deposition of pigment, extracellular pigment between the spaces of Fontani, so the trabecular meshwork pores will reduce in size and perform more resistance to aqueous humor flow. The risk factors of open-angle glaucoma, family history of glaucoma, and ocular disease like ocular hypotension or systemic disease like diabetes mellitus or hypotension. What is the presentation of a patient with open-angle glaucoma? Actually, open-angle glaucoma mostly is asymptomatic. It is discovered accidentally when patient comes to the doctor to examine his eye. But in some condition, it may present with headache, visual field defect, or night blindness. When we do examination to this patient, we will find that there is triad of high intraocular pressure and glaucomatous cupping and visual field defect. The increase in intraocular pressure in open-angle glaucoma is not high as increase in the closed-angle glaucoma, because in closed-angle glaucoma the condition occurs suddenly and in acute pattern, but here it occurs more slowly and progressive. There is some clues to increase our suspicion of glaucoma. The first thing is that there is a difference in both eyes, more than 4 mm mercury. Also, the intraocular pressure difference, diurnal variation between evening and morning, also is more than 8 mm mercury. If we do a propagation test, the propagation test here in open-angle glaucoma, idea is to increase the water consumption of the patient. So it will decrease the osmotic pressure of the intravascular compartment, leading to more flow of fluid from intravascular compartment to extravascular compartment. If the difference of intraocular pressure before and after the test is more than 8 mm mercury, it is a diagnostic of open-angle glaucoma. We also do a tonography. Tonography used to monitor the aqueous humor flow. The second thing is the optic cupping, the changes that occur in the optic disc with high intraocular pressure. Normally, if we draw a simple diagram, this is the optic disc and this is the optic cup in the center of it. It is horizontally oval. At the same time, it is empty of nerve fibers. The nerve fibers will occur here. This is the area of nerve fibers and this is a clear area. In a condition of increased intraocular pressure, the nerve fibers will degenerate and affected and it will disappear. So the area of optic cup becomes more larger and the optic cup disc ratio becomes more than 0.3. This is the first change occurs in optic nerve. The second is the deepening of the cup and becomes vertically oval and appearance of pores of lamina cribrosa and splinter hemorrhage. If we see in this picture, there is a progressive widening of the optic cup and becomes more deep. If we look to this picture, this is the retina, this is the blood vessels, the central retinal artery, and this is the optic disc, and this is the optic cup. It becomes more larger and more wider in this picture. Progressively, it becomes more and more larger until it reaches more than 0.3 the cup and the cup disc ratio. In this picture, the optic cup becomes vertically oval. Here, if we draw a simple diagram, this is the optic disc and this is the optic cup. It is normally horizontally oval because the nerve fiber thickening is more in the superior region and inferior region, following the rule of Essent rule. Inferior more than superior, more than nasal, more than temporal. But in this condition, the more crowding fibers will affected early and affected more. So the first region will be affected is the inferior region, and then the superior region, then the nasal, then the temporal. The optic disc be widened, and widening in this manner becomes vertically oval. In this picture, we see that the blood vessel looks like it become interrupted, but actually the condition is that if this is the optic disc and this is the lamina cribrosa from which the optic nerve fiber exists, because the increase in the intraocular pressure, it push the optic cup more deep in this manner, flask shaped. The blood vessels enter in this manner and passes like this. If we see from in front, we will see this blood vessel and this blood vessel, but this is not will be visible because it is covered by the undermined edge of the flask shape, like this picture. Here is the picture of splinter hemorrhage. Visual field defect in a condition of open-angle glaucoma. We have a central and peripheral visual field defect. The central visual field defect is the presence of isolated paracentral scotoma. Scotoma means that there is islands of blindness in the visual field. This is the macula luti, and this is the optic disc or the blind spot. The first thing occurs is the isolated paracentral scotoma. If this blind spot becomes more vertical or more horizontal, it extends. This is what we call the sided scotoma. Arcuate scotoma, if it extends to the other side but not pass through the lateral raphe. This lateral raphe separates the upper and lower region. This is called arcuate scotoma. If there is arcuate scotoma from this side also, it will cause the ring scotoma. Peripheral visual field defect start with nasal step, then concentric contraction. There is scotoma from the periphery here, concentric contraction and loss of visual field from the periphery. It will continue until it covers all the eye except the central fixation point or the macula. So the patient vision manner is like tunnel vision. Patient vision as he see through a tube. This was the presentation of a condition of open angle glaucoma or simple glaucoma. What is the treatment? The treatment of this condition is essentially medical treatment, except if there is extreme circumstances like intraocular pressure more than 35 mm mercury, or there is impending loss of central fixation point. We start by using one type of eye drop in one eye, monocular therapeutic trial, and follow up by re-examination in 1 to 6 weeks after to assess the visual field and fundus examination. These medical drugs like beta blocker act by decrease the aqueous humor formation and decrease secretion of aqueous humor, like timolol, which used each 12 hours 2 times a day. But we use beta blocker in caution in patient with COPD or hypotension or body arrhythmia or unstable congestive heart failure, in which beta blocker may aggravate or exacerbate the conditions. The second family of drug are parasympathomimetic or myotic drugs, pilocarpine, used 4 times a day. Myotic drugs action is by increase the outflow, increase the aqueous humor drainage. The side effect of this category of drug is visual blurring in the young, darkening of the visual world due to pupillary constriction. the pupil is in a persistent position of meiosis. So if the patient normally in dark light we need meiosis, in dark light we need mydriasis, and in bright light we need meiosis. This patient always in a persistent condition of a meiosis. So if he enter in a dark light or dark room, he cannot accommodate by mydriasis. Ultimately, this will cause to this patient a night blindness. The third group of drugs are prostaglandin analog, latanoprost, used once daily. Prostaglandin analog category of drug act by increased outflow through the accessory pathway, which is the uveoscleral pathway, but it is contraindicated in pregnant women or a woman who wish to become pregnant. Fourth category is by using carbonic anhydrase enzyme inhibitor, which act by decrease the formation of the aqueous humor. Diamox used 2 times a day. The side effect of these drugs is by inhibiting of the carbonic anhydrase enzyme, which presents in the kidney, in the lung. When inhibited in the normal action of carbonic anhydrase enzyme in the kidney is to increase oxalate excretion and decrease potassium excretion. So if it is inhibited, it will lead to accumulation of oxalate in the body and formation of renal stone, and also it will cause increase in potassium excretion and hypokalemia, which manifest by paresthesia. So we give with carbonic anhydrase enzyme potassium tablets. It may also cause a bone marrow depression, manifest as anemia and leukopenia. If we started the management with this patient by these drugs, we must do a follow-up. If the follow-up reveals that there is no decrease in the intraocular pressure or the visual field defect becomes more worse, we must do a surgical intervention. The surgical intervention is by laser trabeculo. There is multiple options. One of them is laser trabeculoplasty. If the intraocular pressure is less than 35 mm mercury, used with medical treatment. Laser trabeculoplasty may used with medical treatment if the intraocular pressure is less than 35 mm mercury. The idea of this is to increase or decrease the resistance of trabecular meshwork to the aqueous humor flow. Surgical intervention indication are failure of medical treatment or deterioration of visual field or inability to follow up. The patient cannot become regular with this follow-up situation. The intervention is by external fistulization operation is the option or the first line by which we do a pathway of the aqueous humor rather than the normal pathway. We create another pathway of the aqueous humor to the subconjunctival space. All the options like defunctional operation not used now. The idea of defunctional operation is to cause by laser, we cause defunction of the ciliary body, no aqueous humor formation by cyclodiathermy. Internal fistulization operation was used in patient with aphakia. There is no lens. We create a pathway, but not under the conjunctiva. We separate the ciliary body, from the sclera, and formation of a suprascleral pathway to be absorbed through the uveal tract vessels. But now, for patient with aphakia, we do external fistulization operation and vitrectomy. Rapid review of treatment. So, if you find a patient with open angle glaucoma or chronic simple glaucoma, the first option is to do medical treatment by using one type of eye drops in one eye with regular follow-up. If you find that this must be done if the intraocular pressure is less than 35 mm mercury. With regular follow-up, if you find that the intraocular pressure decreases to like 15 or 20 mm mercury, and there is no visual field defect, here you will continue with medical treatment. But if the condition becomes worse or the intraocular pressure didn't decrease, you must do surgical intervention. So the surgical intervention, we do it from the start if the intraocular pressure is more than 35 mm mercury or if there is impending loss of the central fixation point. or we do the surgical intervention if the patient starts with medical treatment and there is no improvement. Surgical intervention is by using external fistulizing operation, creating another pathway for aqueous humor flow.